severe acute pancreatitis or even a moderately severe, the patient should ideally be in an intensive care unit. And even with a mild disease, you need to intervene early so that it does not progress to further complications and leads to organ failure. So these are not, airtight compartments. A mild can move to moderately severe or severe very quickly. It doesn't happen the other way. So early identification, even if you have a clinical suspicion and treatment in accordance with that, actually prevents further progress of the disease to a severity. So always remember that these are not static, they are dynamic processes, and one thing can move to the other. So very close monitoring is very, very important. Every 4 to 6 hours, you at least should go at the bedside and review the patient once again. Usman, when it is not moving.
Voice is not.
Is the voice cracking? Hello?
It's proper.
Is the voice okay or is the voice cracking?
No, voice is okay, Dr. Suman.
Okay, thanks. Now coming to the etiology, gallstones and alcohol together account for about 70%. And you should always confirm the etiology because it directly drives your management. Now, one thing that you need to keep in mind, besides the gallstone and alcohol, another etiology called hypertriglyceridemia, especially when the triglyceride is more than 1000 milligrams per deciliter. Because if you have a patient with hypertriglyceridemia causing acute pancreatitis, then you need to intervene very quickly. And a plasmapheresis or an insulin dextrose infusion actually is very, very important to start in these patients before they can move into a severe kind of a disease. In a lot of cases, you will get idiopathic, about 10 to 20% cases where you would not know. Now, when you have a patient with idiopathic acute pancreatitis, and if it is mild, then you should always follow it up with either an endoscopic ultrasound or an MRCP after a first attack to rule out to clear out basically the biliary tree. In a lot of cases, that has been found that you don't get the cause, but if you do an extensive study, then you find out that there is some involvement in the biliary tree. So that is why it is very important. And one more thing that you need to keep in mind is something called sentinel acute pancreatitis event, or SAPE or SAPE. So the first episode, if a patient has an episode of pancreatitis and it resolves, say it is mild, but that kind of sensitizes the pancreatic tissue, especially to alcohol. So if a patient has had a pancreatic episode before and kind of settles down, you don't get the cause, alcohol appears to be not that important, and the patient settles down. But it is very, very important for you to tell or guide your patients that you need to be very, very careful about your intake of alcohol, because if you take significant amount of alcohol after an initial attack of acute pancreatitis, then the pancreatic tissues have been found to be sensitized to alcohol, and they can lead into a very severe kind of pancreatitis later on. And in some cases, you will get autoimmune pancreatitis like IgG4, and that in those cases, steroid is important. So why is the etiology important? Is because it kind of decides on the way you manage the patient. The basic management will remain the same, but for the specific interventions, as you can see in this chart, that if you have a gallstone, then you do an ERCP if there is cholangitis or obstruction. And alcohol, of course, you manage in the regular way. Hypertriglyceridemia, you might need a plasmapheresis, and so on and so forth. Okay. So now coming to the clinical features, we first look at the symptoms. As I said, severe epigastric pain will reduce to the back in about 50% of the patients, and it's more or less a constant kind of a pain. In about 80% of cases, you will have vomiting, and the pain is not relieved by vomiting also. Anorexia is more or less patient in all these patients, essentially because of the abdominal fullness and pain. There is paralytic ileus in severe acute pancreatitis. If it is a biliary involvement or a hepatic involvement, then jaundice is seen. And you tend to get a low-grade fever early on. It is more of an inflammatory response. But if you get fever late, that's after 4 weeks, then it generally indicates an infection. Now, the clinical signs, although the Gray Turner and Cullen Fox's sign are highlighted initially, But what you should look at are the more general signs like tachycardia as part of SIRS or a dehydration, and of course can be induced by pain also. If the patient is dehydrated or there's a lot of third spacing, then you will have hypotension. But in a lot of cases, you will actually get hypertension. That's probably because of a sympathetic drive because of pain. And in a lot of cases, you will see that these patients, they are always asking for a fan in spite of the AC and the ICU, the temperature being maintained at 20-21 degrees because of the SIRS. And you will obviously get guarding and rigidity in the abdomen. And if you probably get either an absent bowel sound or a very sluggish kind of a bowel sound. Now, if you get a Gray Turner, which is a flank bruising, or if you get a Cullen signs periumbilical, these are actually late signs. They appear up to 3 days later. And that actually indicates a hemorrhagic pancreatitis, retroperitoneal hemorrhage. If you get these signs, the importance of them is that if you get these signs, then you should do a CT angio to look for any pseudoaneurysm. And then as probably an interventional radiologic involvement might be required. Now coming to investigations, the initial investigations will include your routine, CBC, then your LFTs, and especially with GGT to look for biliary etiology and serum lipase and amylase, of course. Then a lipid profile in all your patients with pancreatitis. Please do a proper lipid profile, a fasting lipid profile. You do the renal functions and electrolytes, especially looking at the calcium. And you do a serum albumin, of course, to look at the nutritional status of the patient. A coagulation profile is important if any intervention is required later on. You must send paired blood cultures, and you can look for serum LDH. ABGs are important, looking at lactates, which can indicate a severity of the disease. And if there is a problem with the etiology, and you think that autoimmune could be a cause, then you send IgG4, but not to be sent on a routine basis. CRP and procalcitonin are important. CRP of more than 150 at 48 hours and a BUN of more than 20 at 24 hours are robust prognostic markers. It generally indicates severity. So CRP is cheap and you can do it, and it is repetitive. So it is very, very important. A marker of more than 150 at 48 hours, you have to be very, very cautious that this patient can move from, at that point in time, perhaps a mild pancreatitis to a moderately severe or a severe pancreatitis. And BUN essentially also tells you about your hydration status and also the catabolic process going on. So the BUN is high, then it generally indicates an increased rate of catabolism in this patient. So that indicates a more severe kind of pancreatitis, especially if it is elevated after about 24 to 48 hours and consistently remains elevated. Now, for monitoring in the ICU, you do a CRP daily or alternate day, you do a WBC daily, you do a burn at 24 hours, and you keep doing creatinine and serial LFTs. Glucose should be checked for endocrine insufficiency. Now, after the initial evaluation of lipase amylase, and then it is not very, very significant because it does not correlate with the severity of the disease. So we'll keep lipase or amylase level as a marker for the diagnosis that we thought initially, 2 out of 3. But there's no need to do lipase or amylase, especially amylase severely, because it does not correlate with the severity. So that's been proven. Procalcitonin, especially later in the disease, if it is elevated to more than 3.8 or 4, it generally indicates toward an infected necrosis. Now, coming to the prognostic labs, there are various markers such as prognostic scoring, which are there. For that, you might need some hematocrit and rest of the stuff that we do most of the times. You should do a D-dimer for a DIC monitoring in severe acute pancreatitis. Now, coming to imaging, there are various modalities. You can do a CT, an ultrasound, or MRCP, or an endoscopic ultrasound. Now, the cardinal rule of imaging is that do not scan at admission for a typical presentation. When you have pain, abdomen, and you have vomiting and low-grade fever, and the location of the pain, and also you get a high lipase or amylase, then you're more or less sure. So a CT is not to be done initially. But we very often receive patients where the CT has been done on day 1 itself. As I said, it's an unnecessary cost and burden to the patient. It does not give you about the complications of the pancreatitis also, and it can predispose to a contrast-induced nephropathy also. Ultrasound should be the initial imaging that should be done. In a lot of cases, your radiologist will tell you there's too much of gas, I cannot see anything, but it's worth doing it. If there is, especially if there is a biliary component to it, or if there is even a peripancreatic like mild edema or the pancreas is inflamed, the edematous pancreas can be picked up by a good ultrasonologist. Now, when do you do an MRCP or MRI? If you have a suspected CBD stone, or if you have a pancreatic duct integrity problem that you see there is a ascites that has happened and it has suddenly increased in number, then you should start thinking of pancreatic duct disruption. Or it is preferred in pregnancy because of the radiation effect as compared to a CT. And then you have to differentiate between the status of the necrosis for aspiration. For endoscopic ultrasound, as I had said before, if you have an idiopathic acute pancreatitis attack initially, then you should look for a cause and check the biliary tree by an endoscopic ultrasound or an MRCP or MRI. And it is a good guide for walled-off necrosis, and also it avoids radiation. Now, CTSI or CT severity or Balthazar, the modified CT score, is one of the top prognostic markers that has been approved by all the societies for acute pancreatitis. And it is has a scoring from 0 to 4. If there is a normal pancreas, of course, it gets a score of 0. If there is a focal or diffuse pancreatic enlargement, just an enlargement, no collection, it's 1. If you get some amount of peripancreatic fat standing also, then that makes it 2. If there is 1 ill-defined fluid collection is 3. More than or equal to 2 collection with retroperitoneal gas, it makes it 4. So if you get a score of 0, then there is no necrosis. If you get a score of 2, then the necrosis is there, but less than 30%. A score of 4 indicates a 30 to 50% of necrosis, and a score of 6 is more than 50% necrosis, which of course indicates to a severe acute pancreatitis. Coming to the prognostic indicators, a lot of prognostic indicators are there, but what has been really validated, or the ACG 2024 actually recommends that BISAP, okay, and the CTSI, which I showed before, the Balthazar scoring, as preferred tools. So what do you see in BISAP? It is basically BUN, and it's a short form actually. Altered mental status, the signs of SIRS, age of more than 60, and pleural effusion. Okay, so a score of 1 for each. And if you get a score of more than or equal to 3, it is severe. 2 is mild, and of course less than that is moderately severe, and less than that is mild. So concentrate on BISAP. Ranson is something that we have been learning from our MBBS days, and we keep on reading about it, but it has not, it's kind of gone out of practice nowadays. Apache 2, if there is a lot of systemic involvement and other organ involvement, then Apache 2 has a role to play. But otherwise, it is mainly the CTSI and the BISAP, and of course CRP and BUN. CRP, again, I repeat, more than 150 at 48 hours, and a BUN of more than 20 at 24 hours indicates, actually, is a good predictive indicator of the severity of the disease, and you should have in mind. And as I said, if a question comes, which are the preferred prognostic indicators, you should answer it as BISAP and CTSL. Okay. Now we'll move on to the management. Initially, it's supportive care. There are 4 pillars to it: fluids, nutrition, analgesia, and antibiotics. And there are landmark trials which kind of have given us these guidelines. For fluids, we have the waterfall trial, which came out in NEJM in 2022. And there they have said that aggressive versus moderate of linger-acted resuscitation. It has been seen that a moderate goal-directed linger-acted therapy was the preferred one over normal saline. Now, why normal saline is not preferred is because it can worsen the metabolic acidosis that is already there. And if you have a very aggressive fluid resuscitation, then that can actually lead to having more of ARDS and fluid overload without improving the outcome. Now, having said that, you have to be very careful as to which day you are receiving the patient, which day of pancreatitis. The fluid, if a patient is referred from outside, then perhaps they have given adequate amount of fluid. And then if you follow the same rule, then you might overload the patient. Okay. So what you have to do is you have to essentially assess the fluid status of the patient, see for third spacing, look at albumin, and then you take a call on the kind of fluid resuscitation you would do. You can see your IVCs, you can do CRT, you can also do a leg raising test and see fluid responsiveness if you don't have the very high Funda gadgets. These will also guide you, and of course, the clinical assessment of the patient. So be careful about that, it is not a single rule applicable for all, that as soon as the patient comes in, you give her 250 or 500 ml per hour of fluid. No, you will see the fluid status if it comes on day one, and it will generally be dehydrated. But if it is not an index presentation to you, has come to you after 3 to 4 days or 4 to 5 days at times, especially in tertiary care centers, then be very careful about giving the amount of fluid that you would give. Go by your clinical judgment and by the, again, IVC assessment and the other tests that you can do on the bedside if you don't have an advanced or a very hemodynamic monitoring system. Now, coming to analgesia, adequate analgesia has to be a priority. It reduces the stress response, reduces the tachycardia, the elevated blood pressure, and the general well-being of the patient. The Western data says that you can use IV morphine or hydromorphone. We generally use a lot of fentanyl. The modality of choice is, in a lot of cases, you can use epidural, is what they say. It's a gold standard for refractory pain. One more thing, there has been this understanding for a long time that if you have a gallstone pancreatitis, then you should not be giving opioids, but that has been considered to be a myth now. The whole funda was that, it constricts the sphincter of Oddi, so it worsens, but it actually does not. It has been proven that it does not. So please go for good pain management. It can be very frustrating because of irrespective of whatever you do, the patient keeps complaining of pain, especially in the initial days, and then later on it subsides for a few days. And then once it moves into the second week and the patient starts developing a necrosis or a fluid collection, the pain starts coming back again. So you can take help of your intervention pain specialist if you have one. You can put in an epidural and the patient can get relief. Now, another very, very important aspect in management of patients with pancreatitis is the nutrition. Pancreatitis means no food at all. That has completely been taken over. You should not do that. It has caused increase in mortality, not only for the preservation of gut integrity, translocation of bacteria, and it has actually led to poorer outcome. So there has been a Python trial in 2010, which tells you that early oral or enteral nutrition within 24 hours is safe and beneficial. And it has stated that the old dogma of pancreatic rest has been buried. Okay, so protein of 1.2 to 1.5 grams per kg per day should be targeted, and thiamine should be given if it is alcohol related. Protein is important because it is a hypercatabolic state. This disease is a very hypercatabolic disease. Now, coming to the route of administration, what happens is, especially in the later part of the disease, if you have a collection, then it is just behind the lesser sac. So it kind of pushes it forward, and then it gives a picture of a gastric outlet obstruction. So the moment to give the patient some food, they kind of vomit or they don't want to take it because of the complaint of abdominal fullness. So there has been a lot of debate about whether you should be using a nasal gastric tube or a nasal jejunal tube. I mean, the general understanding is that if you can bypass the gastric area and put a nasal jejunal tube, then the patient will be tolerating it better. But there have been a few studies and some RCTs also, which have actually proven that if you give trickle feed, it's not, don't give it as a bolus feed, but give trickle feeds at 30-40 ml per hour through a tube, which is a normal Weil's tube that we put. Suppose you don't have an endoscopic service at your place, or a nasojejunal tube is difficult to put in a situation like that, an NG tube can be placed, and that also suffices. But don't give bolus feed, then that is not tolerated. You give a prokinetic and you give trickle feed, which we say 30-40 ml per hour, 20 ml per hour to start with, then the patient tends to tolerate that better. Antibiotics. Now, this is a huge area of contention. There lots of studies have proven that it is not recommended prophylactically, even in severe acute pancreatitis, unless you get at least a gram stain positive or you have associated other complications. The patient has developed a pneumonia, or the patient has developed a UTI, or something else, then of course an associated infection, that is different. That's a different indication. But even in severe AP, you should not be giving prophylactic antibiotics. This is there in guidelines, this is there everywhere. But what we have seen, and I think most of you will also agree to it, that very rarely will you have people not giving antibiotics even at the start. It's a little sad, but it happens. So try and do that, try and enforce it at your center at least. And it should be reserved for proven or suspected infected necrosis. And this has been proven by two landmark studies, one by Eisenman in 2004 and by Dellinger in 2007. Subsequently, there has been other studies also. Now, if you have to give a pancreatitis later on for necrosis, then two groups of antibiotics work the best. One is carbapenem. No difference between meropenem and imipenem. There is a myth that imipenem works better than meropenem. No. And you can give fluoroquinolones also. If you have a culture, great. If you don't have a culture, even if a smear shows organisms, then if your stain is positive, then you should start antibiotics immediately. Now, if you have a rising WBC later on and a procal which is more than 3.8, especially after about 8 to 10 days, then you should be suspecting an infected necrosis, and that is an indication for you to give antibiotics based on your local antibiogram. Now, coming to the most specific kind of management, you have something. If it's the biliary pancreatitis, then you have a confirmed biliary pancreatitis by an elevated LFTs and a CBD stone on ultrasound or a dilated CBD. Now, if you have obstruction, no obstruction and a mild acute pancreatitis and resolving LFTs and no fever, then no emergent ARCP is required. A laparoscopic cholecystomy should be done in the same admission within 3 to 7 days. Once you see that the pancreatitis is kind of settling down. Now, this has been proven by the Acosta and the Warrior trials. They're very clear that ARCP in mild biliary AP without obstruction is not of much benefit. So no emergency ARCP is to be done. It can actually lead to ARCP related pancreatitis. So that is why you should not be doing it. Intraoperative cholangiogram or intraoperative ultrasound during laparoscopic cholecystomy can be done to check for the biliary tree. Now, if you have cholangitis, that is, you're having fever with chills and rigor, and you already know that there is a possibility of a CBD stone or a dilated CBD. Excuse me, in a situation like that, if you have full-blown features of cholangitis, then ERCP should be done within 24 hours. And that has been the Cochrane studies of Guruswamy and Albulin in 2010 and 2013, which have proven this. And ARCP should be done within 72 hours if there is obstruction but no cholangitis. So if you have cholangitis, within 24 hours. If you don't have cholangitis, then you can wait for 3 days. And sphincterotomy and stone extraction is what is done. An IV antibiotic should be given when you have features of cholangitis. So biliary pancreatitis, no obstruction, mild AP, conservative management. You should do a laparoscopic cholecystectomy in the same admission in about 2 to 3 days once the symptoms settle down. And while you're doing a laparoscopic cholecystectomy, you should do an intraoperative cholangiogram or intraoperative ultrasound. If you have features of obstruction or cholangitis, especially if you have cholangitis with obstruction, you do an ERCP within 24 hours. If you have obstruction, no cholangitis, you defer it for a couple of weeks. And the method is you do a sphincterotomy and stone extraction, and you should give antibiotics if you have features of infection or cholangitis. Now the patient can develop pancreatic necrosis. So what you follow is something called a step-up approach. It has been proven in a 2010 trial initially called the Dutch trial, and then came the tension trial in NEGM 2021, which says that, step up, of course, and endoscopic as compared to an open surgical intervention has been associated with a much, much better outcome and lower rates of major complications. And there was another trial called Pointer trial in 2022, which reinforced the weight principle that delaying first intervention to more than or equal to 4 weeks reduced the number of interventions needed per patient and also the complications with it. So what do you do in phase 1, less than 4 weeks? When there is a sterile or infected necrosis, you do a conservative management And if you feel that it is infected, if you get a culture positive or a stain positive, smear positive, you give antibiotics, carbapenems or fluoroquinolones, and no intervention unless the patient is showing signs of deterioration. Now comes to phase 2, that is between 4 to 8 weeks, and your imaging shows a walled-off necrosis, not ill-defined necrosis, a walled-off necrosis. Then you try and do an endoscopic ultrasound guided drainage if it is infected. Percutaneous drainage is the best way to go about it. Avoid surgery as much as possible. And now in phase 3, if it is more than 8 weeks and there is a persistent walled-off necrosis or it becomes completely organized, then you do an endoscopic necrosectomy called a video-assisted retroperitoneal drainage, or you do a direct endoscopic necrosectomy. And if everything fails, then only you can do an open surgical intervention. So you have to delay it as much as possible. The open surgery has now been associated with a lot of problems, a lot of complications. So we'll try and avoid it as much as possible. Now, if you have a pancreatic necrosis, don't jump into try and draining it. Look at the patient, see how the patient is doing. The more time you allow it to get organized, the better is the outcome. And that can be done in about 60% of the patients. Sterile necrosis, even large volume, can be managed conservatively in more than 60% of cases. Now, when you do an endoscopic ultrasound, then you put something called a lumen apposing metal stent for the walled-off necrosis. Is now the endoscopic gold standard. Of course, it requires a certain amount of expertise, but if you do it, it has the best outcome. Open surgery is a last resort and carries 20 to 40% mortality if you perform it early. Even if you perform it late, the outcome in a lot of cases is not good. Now we look at a detailed protocol of the step-up approach. So in step 1, you do a conservative management, you do a goal-directed, as I said, according to the waterfall trial. You give IV ringer lactate, you give opioid analgesia, start early nutrition, and antibiotics only if there is an infection confirmed or there is a secondary infection. And you monitor with your CRPs, your procalcitonin, your counts, and do a regular vital monitoring, of course. If the patient is deteriorating, then in about 3 days or 40 to 72 hours, you do a CT scan, which is contrast enhanced. And 60% of the patients, as I said, avoid intervention entirely. ICU admission if persistent SIRS or organ failure, or the patient moves from a mild to moderate to severe. Next comes step 2. When we require, you have a walled-off necrosis and you require a percutaneous or a transluminal drainage. You do a CT or a US guided straight away percutaneous, or you go for a retroperitoneal approach essentially, because most of the collection is retroperitoneal, and you continue your antibiotics. Additional drains can be put in for multilocular infections. And this is about, in 35% of cases, this succeeds as a sole intervention. You reassess in about 3 days. If there is a failure, you escalate to step 3. Step 3 is endoscopic or video-assisted necrosectomy, and you put a lumen opposing metal stent, which works the best. Clogged, and you can do it directly under vision endoscopic necrosectomy also, or you can do a video assisted retroperitoneal debridement in the OT. And gold standard for walled-off necrosis at more than or equal to 4 weeks is the US guided lumen opposing metal stent, and about 80% avoid open surgery with this step. Requires expert hepatologist. So when you have a patient going into step 3, please involve a multidisciplinary team where you should have a hepatobiliary team and surgeons involved in it. Don't go by yourself. And now coming to the stage 4, where you have a surgical necrosectomy, that is of course the last resort. As I said, never operate before 4 weeks. The mortality for an early intervention is about 20 to 30% because of the surgery, 20 to 40%, sorry. And you have a post-op sequelae in the formation of fistula, or you have a new onset diabetes mellitus. And again, MDT decision is mandatory before proceeding for a surgical intervention. So what are the complications? There are local and systemic complications. Local complications are, as I said, collection, pseudocyst. You can have a necrosis in the first 4 weeks, and that can go on to a walled-off necrosis. It generally has pressure effects, and rarely you will have pancreatic duct disruption. You can have hemorrhage, which is indicated by your Cullen sign, and you can have a splenic or portal vein thrombosis. It's about 10 to 20% association. So anticoagulation is needed at that time. And another important thing that very often we miss, especially in the later part of the disease, is the abdominal compartment syndrome. Especially in the second week of your pancreatitis, if the patient suddenly develops hypotension and organ involvement, especially the kidneys, and you don't see any infection, the counts are okay, but the BP is not picking up. In fact, so you have to think on the lines of abdominal compartment syndrome, and you know how to measure it. You can use a Foley's catheter and set it up against your CEF measurement manometer, and that helps. So if it is anything above 12 or 15, then you have to start thinking of that. And then if it is about 20 with other organ involvement, then you have a proper abdominal compartment syndrome that needs early and emergent intervention. What could be the systemic complications? You can have a lung involvement. Common association is ARDS. You can have pleural effusion, but unless and until it is coming in the way of your management of the patient, you should not try and tap it. If it is significant, yes. The patient can have cardiovascular shock. Acute kidney injury has a significant association with it. In that, early RRT has been of benefit. And of course, the patient can have sepsis or bacteremia, so you treat with antibiotics in that case. Hyperglycemia is a common association, so you should control it better, but again, not too tight. Pleural effusion, I've already told you, and there could be a long-term recurrence also. This patient can go into an acute, from an acute to a chronic pancreatitis situation. So if you look at this algorithm, it kind of consolidates the entire lecture into a bedside decision framework, where you have acute pancreatitis diagnosed, and you have more than 2 or 3 of the American College of Gastroenterology criteria of characteristic pain, epigastric or left hypochondrium radiating to back with nausea, which is constant in nature, or an amylase or lipase, a special lipase more than or equal to 3 times upper limit of normal. And later on with the imaging, which is a CECT is the gold standard. And 2 out of these 3 gives you a diagnosis. Then you do a quick severity assessment as part of triage. As I told you, mild will be no organ involvement, moderate will be transient organ involvement, and severe will be more than 1 or more than 1 persistent organ involvement or failure. In that case, you do a bicep and the CTSI score. Very convenient is CRP and BUN at 48 hours. If CRP is more than 150, BUN of more than 20, then it indicates the severity of the disease. Now, after doing this assessment, you find mild acute pancreatitis, no SIRS, no organ failure. Then you treat with IV fluids. Lingorectate has been proven by waterfall trial, 250 ml per hour. But of course, please, these are guidelines. You base it on your patient. You know, a patient of poor heart condition or a ESRD who's come to you with acute pancreatitis, obviously you will monitor and do your bedside monitoring of the fluid status by IVC or leg raising or the capillary refill time, and decide on the amount of fluid that you need to be given. And please give proper analgesia. Early oral nutrition is a must within 24 hours, and you do the monitoring. And these patients can actually remain in the ward. If there is a gallstone etiology, then you do a cholecystomy in the same sitting, and of course you do a cholangiogram perioperatively. If the patient is moderately severe AP, these patients either need to be or in an ICU, and aggressive fluid again has to be given with, of course, caution. And you go with enteral nutrition, do a CECT in 48 to 72 hours, and monitor for progression. If the patient goes unfortunately into severe AP, which is persistent SIRF or organ failure, then you need ICU admission, goal-directed fluid resuscitation, and you give noradrenaline if the patient is in shock. Enteral nutrition continues. If the patient develops ARDS or respiratory failure, then of course you need mechanical ventilation. In less than 24 hours, if there is features of cholangitis and a biliary pancreatitis setup, and you do a CCT to look for necrosis and step up, as we have talked about. Necrosis confirmed, you go for a step-up protocol. Antibiotics is given. Firstly, drainage, endoscopically, retroperitoneal approach, then necrosectomy. We can do an endoscopy guided, or you can do a video-assisted retroperitoneal, which is called VARD, or you can do a direct enteral, necrosectomy called DEF. So that is why identifying a patients quickly is very, very important when doing a triage, because if you falter in the initial management, these patients can very, very quickly move from a mild acute pancreatitis to a severe pancreatitis, and then the outcome is anybody's guess. It can go anywhere. So please quickly assess the patient, do the parameters, get an idea about the patient, and then take a call. Fine. These are the references that I took. So that brings me to the end of the talk, and I have a few questions that I'll discuss. Before I move into the questions, me. We'll have 5 MCQs after this.
Good evening, sir.
Good
So,
evening.
what is the role of pancreatic enzyme supplementation? Until what duration we have to give that?
That pancreatic enzyme supplementation is generally once the patient is discharged and a follow-up, and it is more important in a chronic pancreatitis kind of a stage. If the patient recovers from this and from an acute pancreatitis, then you don't need to give pancreatic supplementation.
Until what duration, sir?
If a patient has chronic pancreatitis, then this patient, I mean, it is very difficult to say till what duration, but in general, it has to be continuously given for a pretty significant amount of time. If the patient has malabsorption syndromes and, that kind of a thing, then you have to give that pancreatic supplementation. But in an acute pancreatitis, there is no role of giving pancreatic supplementation.
Any role of steroid for severe acute pancreatitis, sir?
As I said in one of the slides, steroids is indicated only if it is an autoimmune pancreatitis, IgG4. Okay, you should not be using steroid randomly. I know it is used in certain centers that, okay, there is an overwhelming sign of SIRS, let's give some steroids. It should not be done. Only if you're suspecting a autoimmune pancreatitis and you have an IgG4 positive, then the treatment of choice is steroids, but not otherwise.
If there is a procalcitonin highs and patient on inotropic support, suspected secondary infection, then, sir?
Yeah, so if you have a picture of septic shock along with this, okay, then steroids can be given to tide over that period of septic shock. But ideally, you should try and avoid it as much as possible. But suppose you are losing the patient is going down very rapidly, and there is a florid septic shock that has developed because of a bacteremia, which might not necessarily be because of the pancreatitis, but an associated problem. And you are giving the doses of your vasopressors are going up, then of course, or if it's a very severe ARDS early on, you can give steroids, but you have to be careful that, if there is a necrosis developing, then that can predispose to infection. But otherwise, in a case of severe acute pancreatitis, if it is an IgG4 related disease, then that is the indication of giving steroids. See, the thing is that if there is systemic complication coming along with pancreatitis, and you think that that is what is killing the patient, then you need to follow all the guidelines of dealing with the patient, dealing a patient with septic shock. You go into all those interventions. Okay. But just because there is a hyperinflammatory response and there is evidence of a lot of SIRS, then you don't give steroids. I know it is given, but you should not give it.
Sir, metronidazole is also known to cause pancreatitis, but it is also given during the treatment along with Ziplox. How is that possible, sir?
A lot of things are given. So, like I have seen with meropenem, metronidazole is being given. So, absolutely no news. Meropenem covers everything that metronidazole covers. All the anaerobic organisms which metronidazole covers, meropenem covers almost everything. So, what happens is that, especially if the patient is under a surgeon, gastro surgeon, and they have this predilection of giving metronidazole to this patient, it is not indicated. It does not penetrate into especially if there's a necrosis, it does not penetrate into it. That's what a poor penetration. So carbapenems and fluoroquinolones is what you should give.
Any role of ulinastatin, sir?
We use it. Why I did not include it in the slides is because there is no guideline per se, no guidelines mention ulinastatin. So there is this whole list of drugs which have been, said that these are of no use nowadays. Don't use them. So illuminastatin is one of them that is, we use it. I myself use it, but at times it is a very severe pancreatitis. We do use it. In some patients, it appears as if, but that is, you can't hold that as data. I think probably you should just use it in your own discretion. It doesn't cause too much of harm, so you might use it. But how much of benefit it will cause is anybody's guess.
Okay,
Sir, if someone is having choledocholitis and ERCP is being done for that, and patient had not any symptom of pancreatitis, after how much duration should we go for the cholecystectomy?
Can I just repeat the question? You have a CBD choledocholitis, ERCP is being done.
And after how much time cholecystectomy should be planned?
So you're not saying that, okay, you're not saying that there is a stone in the gallbladder. You're saying there's a stone in the CBD.
There's stone in the gallbladder also, sir.
Stone in the gallbladder also. Yeah. So the thing is that if the patient does not have any features of pancreatitis, then you can do it in the same sitting, or you can do it 2 to 3 days later.
Thank you, sir.
But ideally, what they do is when they do a laparoscopic cholecystectomy, then they do a CBD exploration also. You should always do a CBD exploration. So in that case, an ERCP might not be required. Because ERCP has its own risk of causing pancreatitis as a complication. Anybody knows why?
Because sometimes wire or goes into the pancreatic duct.
Yes, there's a causal duct damage to the duct. That is the most important thing.
Or they are using dye, which also damages the pancreatic.
Yes, it does. Yes, it does. Now, one more thing which I would want to stress on for all of you is that when you are having a patient of acute pancreatitis, please always do lipid profiling. We very often see patients in whom this has not been done, and they've been, come to us as a uncertain diagnosis, idiopathic pancreatitis. And then we have done triglycerides, and we have actually had 2 or 3 patients with 1500 of triglyceride, in which we did plasmapheresis, and the patients improved. Another situation that happens is that, most often we associate hypocalcemia with acute pancreatitis. Can you tell me the reason for that?
Due to saponification of fats.
Yes, the fat globules saponification. Now you have acute pancreatitis and you have hypercalcemia. When will that happen?
Due to parathyroid adenoma.
Absolutely. So very strange. We had 4 consecutive cases of pancreatitis where we could not find other causes, and the calcium turned out to be 12 or 13. And then we did the scanning of the parathyroid. We found that the patients had parathyroid adenoma. So, these are the various kind of variants which you can find in pancreatitis. And of course, you should look at the list of drugs that can cause pancreatitis, especially in HIV, especially on ART. A lot of these NNRs, they actually cause pancreatitis. So be careful about that. Should we move on to the set of questions? MCQs?
Yes, sir.
Yes.
Yes, sir.
Let's move on. So here comes question 1. 44-year-old male, within 12 hours, history of severe epigastric pain radiating to the back, vomiting, low-grade fever. Serum lipase is high, more than, obviously 5 times of the upper limit. Has tachycardia, borderline blood pressure, mildly tachypneic, low-grade temperature, urine output of over 2 hours is little on the lesser side. Biceps score is 3. The ABG shows mild acidosis with raised lactate. Ultrasound confirms cholelithiasis. CT is appropriately deferred. He's admitted to the ICU. Because why is admitted to the ICU? Why is this patient in the ICU?
Biceps score 3.
Biceps score 3. Very good.
Yeah.
So now, which of the following represents the most evidence-based fluid resuscitation strategy in this patient? You give an aggressive normal saline or goal-directed Lingard's lactate to titrate to urine output of more than 0.5 or a heart rate of less than 100. Colloid-based resuscitation with 20% albumin at 100 ml per hour to maintain oncotic pressure and reduce the spacing. Aggressive resuscitation with normal saline at a fixed rate of 1000 ml per hour for 24 hours. or restrict IV fluids to under 1 liter per day and use vasopressors only to minimize the risk of abdominal compartment syndrome.
B.
Which one do you think?
B,
12
sir.
ones.
B.
Yeah, and what was the trial I mentioned?
Waterfall.
Yes, for EFIC students, you
Waterfall.
must remember this landmark. Yeah, for especially if there is any EFIC candidate over here, for you guys, it is very important to know the landmark trial. Okay, so waterfall trial will actually come up with this that ringer lactate is more important, and this is the goal-directed therapy. Having said that, please always assess your patient and see the day of presentation and the status of the patient before you give this kind of therapy. Okay, so that was easy. Now moving on to the next question. 62-year-old woman presents with acute pancreatitis, has a temperature of 39.1, tachycardia, low BP on the lower side, has a jaundice of 7.2, ultrasound confirms correlates, and a dilated CBT measuring 39. So the ALT is 340, ALP is 520, GGT is elevated, has right upper quadrant tenderness. Blood cultures are sent, biceps core is 3, so severe acute pancreatitis. Started on IV tazocine and aggressive fluid resuscitation. Biliary obstruction with concurrent sepsis is suspected clinically. So what is the most appropriate next step? Anyone?
Obstructive.
Yes, sir.
Sir,
What is the
A, sir. A, sir. A.
Yeah, perfect. Why A?
Obstructive.
Confirmed case of cholangitis.
Yeah.
Yeah, so there is obstruction
CBT,
and cholangitis.
CBT stone is there. Yeah.
Yeah,
Cholelithiasis.
yeah, so if there is obstruction, what is indicating obstruction? The bilirubin being high and the transaminitis and the GGT, right?
Yes.
ALP and
That is
GGT.
indicating obstruction, yes. And the patient has fever, and so we have a CBT stone with fever, with low blood pressure. So it is indicating cholangitis. So very urgently, you should do an ERCP within 24 hours. Okay. Does anybody know what is Charcot's triad?
Charcot's triad.
Fever, pain, and vomiting, sir.
Yeah, and so what is Reynolds pentad?
Fever, pain,
So Reynolds
vomiting,
pentad
jaundice, and
Fever, jaundice, hypotension.
Yeah, correct. So Charcot's triad is basically, sorry, pentad is Reynolds pentad is Charcot's triad plus hemodynamic instability and features of cholangitis. Okay.
yes, sir.
So for if there are any EPIC students, this is guided by the ACG 2024 and the British Society of Gastroenterology 2020 guideline of doing an ERCP within 24 hours. Okay, and it has been indicated in the two trials of Acosta and Oria that ERCP is only beneficial when there is biliary obstruction or cholangitis. Without this, urgent ERCP offers no benefit, okay, for uncertain CVD stones. Okay, but if you have, again, if you have features of cholangitis, please do an ERCP urgent. Moving on to question 3. 48-year-old male on day 16 of severe acute pancreatitis. Mark the day 16, okay? So it's like mid-third week. Initial CECT showed more than 50% pancreatic necrosis with a CTSI score of 8, so that is severe. He was managed conservatively. IV meropenem was started 5 days ago after the procal rose to 5.2. So 3.8 was the cutoff. Despite antibiotics, he remains febrile, has an elevated WBC, CRP of 298. Repeat CECT now shows gas bubbles within the necrotic collection. What does this mean?
Infection. Necrosis.
Infected
Necrosis.
necrosis.
It is infected necrosis. Once the moment you see gas bubbles, it is infected necrosis. He is hemodynamically stable with a MAP of 72 and no vasopressors. So adhering to the step-up approach, what is the most appropriate next intervention? Read the choices and let me know.
CT guided
B.
or ultrasound guided percutaneous,
B.
sir? C, sir.
C, sir.
C, sir.
C?
C.
Most
C.
of you are saying C.
C.
B.
Why? B. Okay.
Not indicated. Sir, we have to drain that
Anyone else?
source control.
B, sir.
Source control.
We'll wait for 4 weeks.
Sir, B.
No, hemodynamically it's stable, but the CRP is elevated is maybe not due to the infection, sir. So we can wait 2 weeks. So it's C.
See, because source control is required, sir.
PCT is more 5.2, sir.
Will you do?
Sir, B because of 16th day of pancreatitis.
So you're saying if you do anything before 4 weeks, then there is a problem.
Yes, sir.
In this case, it's a very difficult situation. That is why I gave this thing, because there is a lot of evidence of infection in this. You have an infected necrosis. Okay, you have a very elevated CRP, and you also have, but the thing is that the blood pressure is stable. Okay, so if you can have to monitor the patient very carefully, and if you can push it to 4 weeks, because that is when it's walled off very nicely, it's the thing that will come to your mind very, very quickly. But in this situation, it is a CT ultrasound guided percutaneous catheter drainage. That is the first that's the step that you should be taking. So in a situation like this, because the repeat CT had shown gas bubbles with a raised procalcitonin, with a raised WBC, the patient is febrile. In a situation like this, you have to do a source control and do a CT ultrasound guided percutaneous catheter drainage. Okay. So although the indication is that the studies have been proven that if you can take it to more than 4 weeks, then you have the best possible outcome. But in a situation like this, when you have so many markers which are indicating towards a very severe disease with an infective component going on, then the stability of the blood pressure or the hemodynamic stability might not persist for long. So along with the antibiotics, you should be doing a CT guided or an ultrasound guided drainage of the necrosis. Okay, so that is why I gave this question, because there's a bit of a catch in this. Okay, coming to question number 4. Now you have a 39-year-old male with severe acute pancreatitis. Etiology is unknown. On day 4, he received 6 liters ringalactate in 24 hours, has tachycardia, low BP, on adrenaline at 0.3 mics per kg per minute. Saturation is low on an FiO2 of 60%. PO2 to FiO2 ratio is 136, is tachypnic. Urine output is low, creatinine is elevated. The peak inspiratory pressure 38 centimeters of water. Abdomen is grossly distended, and tense intra-abdominal pressure measurement is of 24 millimeters of mercury. So which statement is most accurate regarding the patient's clinical condition and immediate management?
Abdominal compartment syndrome, sir. C.
All of you agree to that?
Yes.
Yes, sir.
Can
C.
hear only one voice. All of you agreeing to it? So this is
Yes.
classical
Yes.
abdominal compartment syndrome. Classical abdominal compartment syndrome. And so what do you do when you have abdominal? So what is intra-abdominal hypertension and what is intra-abdominal compartment syndrome? What's the difference?
In hypertension, sir, only pressure is rise. In compartment syndrome, decrease urine output.
And also AKI.
Yeah. So if you have a raised intra-abdominal pressure with organ involvement, especially the kidney involvement, then that is abdominal compartment syndrome. But if you have it around 12 to 15 or everything up to 18, then that is an intra-abdominal hypertension. But that is the time when you should start looking at your fluids, because that is the most important cause. Of course, you have a huge amount of abdominal distension, then start the decompressive therapy. Don't allow the patient to go to ACS. Okay, so if you have a huge distension of the patient's abdomen, then do an intra-abdominal. It's such an easy bedside procedure to do. So do it, and then you can guide it in accordance. Okay. So what are the measures that you can take for abdominal compartment syndrome? What all can you do?
Diuretics.
That's right. You go for a negative fluid. You try to bring out the fluid. What else?
Abdominal drain.
You can do a nasogastric or a rectal decompression. And if this patient is on ventilator, do not allow the patient to fight too much. Give an optimal sedation to the patient. And also, if there is an acute kidney involvement in that, then of course you need to do an RIT. And if it is completely refractory, then you do a decompressive laparotomy. Okay. Don't make the mistake when you're suspecting, when you have high intra-abdominal pressures and you have a low blood pressure, of giving more fluid. You know,
Yes.
I have seen this happening that, you know, third spacing, give colloid. And you do an intra-abdominal pressure, when the pressure was 12 initially, has gone up to 20 now. So it's a very, very common mistake that is done. And again, if you have hypotension with abdominal compartment syndrome, then that is not an indication for giving antibiotics. It is very often extrapolated to that it will lead to gangrene of the gut. You release the pressure and the patient will become all right. So no excess fluid to treat the hypotension, because that is probably the cause of the intra-abdominal hypertension. So be very careful, okay? Be very mindful. Now the last question. 36-year-old obese male, BMI of more than 37, with type 2 diabetes on lipid-lowering therapy, presents with severe acute pancreatitis, no history of alcohol use, and ultrasound shows no gallstones. Triglyceride is immensely high. Calcium is normal. He is admitted to ICU, bicep of 3, tachycardia, low BP, lactates high, creatinine elevated, started on goal-directed resuscitation. NG tube is placed for early internal nutrition. CCEF is planned up to 3 days. So in addition to standard ICU supportive care, which specific intervention is most appropriate?
C, sir.
Why not B?
Insulin dextrose.
Why not B? How does plasmapheresis help? How does insulin dextrose help? How does it work?
Insulin dextrose helps.
If you're going for C, then how do you think that will help? Plasmapheresis, it directly removes the triglyceride.
Triglycerides. Yeah.
And if you give an insulin dextrose infusion, then what that does is it activates the lipoprotein lipase, which breaks down the VLDL component. So that is how it helps. So what about B, IV heparin infusion? Why is that not an option? It's cheaper, right? As compared to plasmapheresis. Why would you not go for that?
It will not acutely lower that much of triglyceride level.
What it does is it does reduce, it activates the lipoprotein lipase when you give an IV heparin infusion, but that's a very transient kind of a phenomenon. It's within 24 hours, the whole thing reverts, and then the features come back. So it is a very transient thing. So it is not really persistent in its effect. Much more effective plasmapheresis or insulin dextrose infusion. If plasmapheresis is not present in your hospital, give insulin dextrose. It also works. Okay. And
Yes.
remember that in a situation like this, you try to give enteral nutrition via an esophageal or gastric tube, and it is still preferred over a TPN. TPN you should avoid, especially when you have a hypertriglyceridemia, which is understandable, right? So that is what you
Yes,
should be avoiding. So thank you very much for